Hi, good afternoon, and welcome. Thank you all for joining us today. I'm Samantha Mokas, and I'm the director of the Florida Association of ACOs. We are excited for this opportunity to present to you with the next installment of our webinar series, Improving Health Outcomes, Addressing Social Determinants of Health. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen and view your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit test questions to today's presenter by typing your questions into the Windows pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer session at the end of today's presentation. With that, I'm going to turn the presentation over to Dr. Alan Daniels.
Good afternoon, and thank you, Samantha. I'm pleased to welcome you all to this webinar on improving health outcomes, addressing the social determinants of health. And I will be serving as the moderator for today's discussion. Introducing our panelists, we have Dr. David Nash, who's the founding Dean Emeritus at Jefferson College of Population Health. He's also the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy. And with him is Dr. Harm Scherpbier, who is the Chief Medical Information Officer for InfoMC, Health Analytics Faculty at Jefferson College of Population Health. What we will be doing today, a brief overview. It will be a moderated discussion of leaders in the field. We'll be covering three main topics, and the way in which this webinar will work is it's intended to be a dialogue rather than simply a presentation of material. We'll be covering the role of social determinants in population health initiatives and the relevance to group practices, ACOs, clinically integrated networks. Second, how social determinants impact healthcare services in healthcare outcomes. And finally, how technology tools can impact and improve care coordination services for population health outcomes. We are not going to be presenting slides, graphs that are oftentimes common in webinars, but we have a ton of materials that are available. And at the conclusion of this hour, we will share with you how you can achieve those and how you can reach us. And we'll be glad to provide any information and welcome your follow-up at the conclusion. So with that, I'm going to turn the first question to David. And the question is, what has led to the recent interest in social determinants? Is this a new phenomenon or something that healthcare has always addressed? Your thoughts, David?
Well, first of all, thank you, Alan. Thank you, Harm. Great to be together. I hope everybody had a wonderful holiday, and wonderful that we're doing this special program. I really appreciate the support from InfoMC. So, wow, what's led to the recent interest? Yeah, it seems like all of a sudden in the last maybe 3 to 5 years, the country has awakened to the fact that 80+% of somebody's health has nothing whatsoever to do with the healthcare system and has all to do with their zip code, their level of education, the crime in their community, their parents, and all the things that we have finally come to call the social determinants of health. So in a way, maybe it's a paradox, maybe it's just irony, but finally, the nation is coming to grips with the research evidence that health care services are 10 to 20% of the story. The other 80+% of what makes us healthy has nothing to do with the healthcare system. And please note that Harm and I are sitting inside Jefferson Health, a 16-hospital, $5 billion, the largest delivery system in the Philadelphia market, where I have been a faculty member for 30 years. So I guess it's a new phenomenon, although, of course, the research evidence would support that it's been decades that we've been obviously thinking about the social determinants, but this term has really made it into the lexicon in the last couple of years. So that, I think that's my perspective.
Hi, this is Harm. There's two things I'd like to add that can explain why we're suddenly looking at the social determinants. One of them is the fact that the data has become available, that we now have large data sets that allow us to look at, and we'll talk about that later, but that suddenly that data becomes available and therefore more useful in our addressing populations of health. So that also added to the sudden interest in social determinants. The other thing, and we'll talk about that more, is the fact that our payment model has changed. And therefore, organizations are now responsible for groups of patients, for populations, and now they look not only at their healthcare needs, but at their whole needs and how can we keep these people healthy. I think those are factors that drive the interest, and it also drives to expand health organizations to look beyond the traditional who's my patient,
right?
Like who's my population,
right?
And that makes this so much more interesting.
Well, Harm, you and I were trained a long time ago, especially yours truly, in a model of one patient, one problem, one at a time, and whatever happened outside the walls of the office of the hospital were none of our darn business. And I think that's the extant model, certainly for any primary care doctor over 55 or over 60 in my case. That was the prevalent model, and so since we comprise most of the faculty and most of the deans, that's how most of the current crew got trained. So it's no surprise that every system is perfectly designed to achieve exactly the results it gets.
Yep.
So I think what you both are saying is that it's an evolving trend, but money, population health, and quality of care are starting to drive some of these changes.
I think that's a fair assessment, Alan, and I hope that around the Thanksgiving table, everybody listening in today, which is really wonderful, I hope they all had a chance to talk with their families about the nation's biggest business, which is our business, healthcare, and where we're going as a country, spending almost 20% of the GDP of the world's largest economic engine on healthcare. And we'll talk later, as Harm suggested, what are we getting for this investment?
Mm-hmm.
Well, and a placeholder for that when we get there in a minute. I'm going to skip to the next question in a second, but is when the percentage of dollars spent are they calculated on healthcare, or are they calculated on the total cost related to some of these social determinant issues?
Well, it's a great question. So the percentage of GDP is calculated on total spending for all goods and services. The 80% figure is then calculated on that 20%. In other words, what contributes to health, we know pretty conclusively now from the work of a score of people from David Kindig on through Elizabeth Bradley, that health, as we define it, 80% of it is attributable to those social determinants. And in our country, poverty being the singular most important driver of poor health, which is a complicated issue for us. In the rest of the Western world, that direct connection is much more tenuous, meaning in the United States, if you're poor, with all due respect, you're screwed. And that's the punchline.
Yep, I think that's right. Let me move us on to our next question. Harm, I'm going to pose this one for you to kick us off on. So in order to address individuals with social determinant challenges, we need data to identify which members of a population have the highest needs. Can you talk some about what the best way to do this is and what assessments, data elements, personal information are important to collect?
Yeah, there are multiple ways to acquire social determinants of health data. Let's first decide what data that is. That means data about either an individual or about a population, about their economic situation, about their education, about their employment, about their home ownership, about their food availability, about their environment, all those data that together make up someone's social determinants of health. There are a number of ways to get that data. One of them, most electronic medical records companies today include in their electronic medical record an assessment that allow the care managers, the nurses, the physicians to have this conversation with their patient and not only know about their sudden onset of their disease, but also about, do you live by yourself? And where do you get your food? So some social determinants are becoming part of the assessment that many EMR companies now include in their templates and allow hospitals to collect. So that's one way. we'll talk in a minute about the pros and cons of each. Another way is by coding. ICD-10, which we traditionally used for coding diseases, is now also coding for social determinants. There's a number of ICD-10 codes that our coders can include, and that many health payers are asking them to include, so that they get an understanding. Right? It's about time, because it's part of the what drives someone's healthcare needs. These are drivers of healthcare needs. Might as well code them and know what they are. And the third big factor is through data sets. Like I said earlier, there are many data sets. Some of them are publicly available. Some of them are available through private companies that allow you to get data sets on populations by zip code or by census tract. There's a great paper by Bazemore, which I will include in my follow-up materials, that calls these community vital signs. In other words, these are the vital signs for a community. These are the numbers that allow you to understand what is a community about, what is the home ownership, poverty, education level, etc., crime level in that community. And that is a data set that you can combine with your healthcare data set to get a better insight for the needs of a population. I prefer that we look at all of these, not either or, but all, because there's pros and cons. It's, of course, very nice if we can collect this data directly from the patient. The downside is that I'm only then having the data for those patients that are coming to see me, and I'm missing on the rest of my population for whom I'm still responsible for, but they haven't come in for a visit or an admission, and I may miss that data. So it's good for those patients that end up visiting your health system, and for them you have the data. But what I like about the data set approach, the database approach, is that you'll then get that data for the entire population.
Yeah, I'm going to jump in. I got to interrupt you, Harm. It's just so great to be together to do this. And thanks again for all of your hard work for our college, too. So, I'm sitting here thinking about my RVUs, and I don't really give a darn about that population health measures, because there's nothing to do with my RVUs. And if I'm not productive, my RVUs are going to go down and I'm going to get paid less. So to your prior point, we have to change the payment system. And hopefully we'll get to that today.
Absolutely. Because
without that, I don't have a rational economic incentive to really care about those population health measures, right?
That's absolutely right. So if a practice is paid purely based on fee-for-service payments, they would not pay attention to this.
And even advanced fee-for-service productivity measures, forget it.
Yep.
Even if I'm NCQA certified and I'm still paid on a procedural or per-head basis, none of that stuff is of interest to me.
But luckily, a greater and greater number of our doctors are being paid for a value-based payment, capitation, or at least a part of an at-risk Medicare shared service plan. So that drives the broader interest in these patients, like where are my high-risk patients?
Right, and getting back to Alan's question, I think that, collecting the information. So who's going to do that? Who's going to collect those social determinants? Maybe you ought to chat about that for a moment.
Yeah, so like I said, the ones that are, you're able, health systems are able, and I see this quite a bit right now, to collect the data at the point of care from the patient.
But do you want me as the primary care doctor to do that? I sure hope not.
I think it's done usually by a nurse or medical assistant or a care manager, often by a care manager through a care management system. And the care manager often has a much more tight relationship with the patient, especially with high-cost, high-need patients. So they're in a good position to have this conversation with the patient and understand their social determinant needs. I think collecting the data from the patient is great for those patients that have high needs. But like I said earlier, it's a fairly time-consuming process to do this. It's not always the most comfortable conversation.
Right, and how do we standardize all this, too? Where do I even put it in the EPIC record?
No, EPIC has now a place for
it. A little place.
And so does Cerner, and so all these EMR companies have a place to store and collect the data. But I think that's a partial solution. Okay. I think the broader solution is to combine that data with the quote-unquote community vital signs, either through publicly available data from the Census Bureau or from the American Community Survey, or from data sets that a health system could purchase from a commercial vendor that sells data sets.
Got it.
Well, and I think for both of you, though, we also need to keep in mind, and I think, David, you raised the issue of how we've trained people, because I'm reminded of the screening on a recent primary care visit I had where the nurse was going through the series of questions, and came to the question about, do I feel safe and do I feel threatened? And she jokingly said, by anybody other than your wife, which
right.
Fortunately, I'm not threatened by my wife and don't have to worry about it. But for somebody who was, they might have just dismissed that question out of hand and lost the important content that could have been there.
Sure. No, I get it. And I think we're taking some important baby steps in the right direction. But you can't argue that we're still way behind in how we collect even and organize this kind of information and make it actionable for people like me in the primary care setting.
If I were making a recommendation to an organization who hasn't done anything in this field to make the first move, I'd say the first step should be that you take your patient database and combine it by zip code to a census tract poverty index.
That'll help.
Just start with poverty.
Start with poverty, right.
Because ultimately everything ends up with poverty.
Yep.
Start by looking at one parameter only, poverty, and by zip code you'll see a percent at poverty. That will be your first social determinant number, and you will see how that number lines up pretty much with your readmission rate and with your ED visit rate and with your hospital admission rate. These numbers line up, and I think it's important that you notice that and are able to act on it. So percent poverty from the census tract.
Well, let's remind our listeners too, we're sitting in the great city of the founding city of our nation, right? Where 1 out of 4 people lives in poverty, and half of those live in what Uncle Sam calls deep poverty, meaning no food on the table. So when you're in a city with 1 out of 4 people living in poverty, that creates all kinds of challenges to the population health agenda, for sure. And let's also remind them we're in a city with 5 academic medical centers, which includes 2 of the largest private medical schools in America, Sidney Kimmel Medical College, Jefferson, and Drexel University College of Medicine together. That's 5% of all doctors in training in our country are in Philadelphia, right where we're sitting, Harm. So that's a real challenge too.
I think that's really important. I think that's a really important comment. I'm going to move us on to the next question in just a second.
We don't have any passion for these questions, Alan. You could probably tell.
Right. No, it's. I worry about getting us through all of them, but we'll make it. I do want to comment though that for future questions as we're talking, we talked about information that's available in the electronic health record, but we're increasingly building the scope of who is involved in healthcare such that there's payers, care coordinators across different systems that may or may not have access to the health record. So let's keep that in mind. But let me move us on, if I might, because I think one of the key questions for our audience is going to be, what about the return on investment? Is there a return for investing in social determinants for covered populations, for individual patients? How do they impact health plans, payers, group practices, ACOs, and others as payment models shift? Your thoughts on those issues?
Sure. So let me tackle this first, I guess. So the short answer to your question 3, is there evidence of a return on investment for addressing the social determinants? The answer is a resounding yes, but it depends on who's getting paid and who's collecting the revenue. In a capitated environment or in a Medicare Advantage HMO environment, I think the research evidence is very conclusive that there's a strong return on investment. Let's tell some stories to illustrate the point. So, my late mother lived in zip code 33437, which our listeners know is ground zero of Medicare overutilization, right? The east coast of Florida, north of Fort Lauderdale, south of West Palm, ground zero. On a per capita basis, more stuff gets done to more people for no darn good reason than anywhere in the country. So that was the extant healthcare system, in quotes, in Southeast Florida. In a capitated world, in a world of the Humana, United, Aetna's, and Medicare Advantage world, when Mom was still alive, they sent folks to take the shag rug out of her bathroom after Dad died because they didn't want Mom to slip and fall and break her hip. So the return on that investment was pretty great. You know, a social worker going to the house, checking on mom, getting that shag rug out, checking on her meds. That's a gigantic positive ROI. How about when they took mom in the senior van to the senior center so she could meet other widows her age, because we know that loneliness leads to depression, which leads to dementia. So would you rather get them to the senior center in that van, or treat dementia in an inpatient, living arrangement? So look, there's no question that the return on investment is there, but it all depends on the payment system, as Harm alluded to earlier. So the second part of your question, Alan, is a tough one. The health plans, payers, group practices, ACOs. Well, I would say for payers who have capitated or value-based programs, and for ACOs and group practices who are part of that, sure, there's a solid return on this investment. That would be my approach.
I would also like to illustrate it as an example. So there are practices and practice organizations popping up that focus specifically on this model.
Exactly.
Oak Street Health is an example, based in Chicago, but with practices also in many cities in the country. GenMed, I think
mostly
out of Florida, mostly in Florida. What's unique about those practices? They focus on elderly Medicare patients with high utilization.
It's amazing.
And they sign up those patients.
You're sick, you're tired.
Bring the sick and tired, and sign them up under a full risk Medicare Advantage plan.
Right.
And once you have these patients with a full risk Medicare Advantage plan and start managing them by very, very focused care management, using care coordination with a team, a care coordinator, a nurse, a behavioral health person, a social worker, to really start addressing, that's when you get the ROI for these practices. So it addresses not only these patients' healthcare needs, it addresses their social needs. If they need transportation, GenMed provides transportation.
Yeah.
If they need food help, GenMed or Oak Street provide that. So I think it is the holistic view, but specifically the ROI for selecting that population going at risk and delivering.
But they've got to be at economic risk. Otherwise, all those expenses are not contributory in a traditional payment method. I would add, so great that you brought up GenMed and Oak Street. Right here in Philly, of course, we have both of those, and IORA, and Absolute Care, all of these amazing companies, a totally different model than I was ever exposed to. And I've had the privilege of visiting all of these places, IORA, Oak Street, Absolute Care, and GenMed, face-to-face.
Yep.
So I want to tell our listeners another great story, because that's how grown-ups learn, right? So, when I visited Absolute Care, they were talking about that their van drivers are part of the daily huddle. And I sort of, what? How's that work? So why would you have the van driver sit with the social worker and the doctors? Well, guess what? He knows that Mrs. Jones, in her 5-story walk-up, there's no elevator, and the reason she doesn't come for her visit is she can't get up and down the steps. Right? Now, how would you possibly know that? And the other thing I love about that, I attended one of the daily huddles, and they asked the question, who is not here today who needs to be? It took my breath away, right? Instead of my practice, here's your list, get busy.
Yeah, exactly.
Right? And they were asking the question, why isn't Mrs. Jones here? Instead of, here's Mr. Smith and, so on. So it's a completely different model. And I think they're going to need another new type of doctor, too. Somebody who is comfortable with closure of the feedback loop and understanding their performance, where are their gaps in care, being open to feedback about closing those gaps. I've been in practice for 35 years, Harm, here in, Philly. No one has ever sat down with me to say, David, here's 6 things you could do better. And believe me, there's probably more than 6. So I think those group practices we talked about, that's a powerful story about their return on investment.
What you just said, I think, is also the definition of population health.
That's
and
right.
The definition of value-based care. Not only taking care of patients who are there, but specifically focusing on patients who are not there. They're in your panel. You're at risk for them. But if they don't come to you, you need to manage their care anyway. So I think it's another argument to be made for care coordination and care management and proactively seeking out those patients, even if they don't show up in your
Yeah, and I think we should also add, just for this question, is as best as we could tell, Iora, ChenMed, Absolute Care, and Oak Street make a margin.
They do.
On these super sick patients. So what do they know that we haven't been able to figure out?
Absolutely.
Right?
And the second part, so if they make a margin,
right,
who are they taking that margin
from? Right.
We know the answer.
Yes.
Who is it, David?
Yeah, it's a good question.
Where are they taking it from?
Yeah, who are they taking it from?
They're taking it from
us. Right. Right.
Acute care health.
It's a little scary sitting here inside the belly of the beast, Harm. Right. Don't talk too loud.
I think it's the right thing to do.
Of course.
I always think this is the best for the patient.
Well, they're going to eat our primary care lunch if we're not careful.
Absolutely. Right. Yep. They set the bar.
So let me move us ahead, if I might, to the next questions. But in wrapping this one up, I think one element that you might want to build into some of your answers as we move forward is, certainly social determinant risk has issues for the elderly in terms of loneliness and some of those issues. But I do believe it's probably very different across the lifespan with children and youth and families. And so we might want to talk some as we move forward also on the challenges that face diverse populations across the entire lifespan. But you guys touched on this, and let me bring us up to the next question, which is, I've heard physicians and other healthcare providers saying that these are not my problems, and these are not anything that I should have to worry about. It's outside the scope of my clinical practice. And so how should payers, providers, and other systems of care address social determinants? Which staff are the best positioned to do this? And are there best practices, examples, and you've touched some of these, on how this has been accomplished?
Yeah, let me tackle this first, because I have had the privilege this year of speaking at 2 national Pri-Med conferences in Fort Lauderdale and in Chicago. So this is, thousands of primary care doctors from across the country at these 2 big events. It was amazing. And I got asked this very specifically. And so we know that accumulating research evidence shows that if you want to reduce burnout, one of the ways to reduce burnout is give doctors the tools to tackle these social determinants. Mm-hmm. That prescription for food, the script for transportation, the script for a social worker consultation because I'm being evicted from my apartment. We know now from survey research in family medicine in particular that docs, when they have the tools and the training, this actually reduces the risk of burnout. So I think that's one important point. I think the second point is, what is the core business that we're really in? Is it improving health, or is it checking the box that I did that process measure for quality, right? So if I'm really all about improving health, then I have to tackle those social determinants. Now, I don't necessarily have to, go to court, talk to the landlord, etc., but I have to be the quarterback, the captain of the team, whatever analogy you like, to help allocate the resources and the people power to tackle these questions. Yeah. Otherwise, we're just spinning our wheels. Yeah. So I think we're in a new era, especially for primary care doctors, that if they have the team, it's a very satisfying kind of practice to be in. Frankly, probably more satisfying than the kind I grew up in. That would be my view.
Yep. Keyword, David, we just said is team. I think we're shifting from a model where it used to be the doctor doing the bulk of the work. That goes away. Yeah. We need to focus on this as a team.
As much as I loved Marcus Welby, I think he's probably dead and buried.
Yes, yes.
I did really love that program.
And if that were today, we'd have to surround Marcus with
the whole team,
support team.
And he wouldn't know what to do with them.
He would probably also have a higher satisfaction. But I think some of the things that the physician, he or she, wouldn't do is currently being done by social workers, behavioral health personnel, care managers. Care managers, care coordinators, I think, are key. They're quarterbacking the care for that patient. And I think they are so important to this. So, number one, I think practices need to invest in not only their providers, but in a much broader team to help address this and to be effective. Otherwise, you cannot even effectively do it. The second thing, besides team, you said, I was going to say, realization that your revenue is based on the full contract. Is based that you're being rewarded based on acute care utilization. You're being rewarded for keeping patients out of the ED, out of the hospital. As soon as you realize that is now part of my payment, then this becomes a smaller step.
Again, stories tell the story, right? So a number of years ago, I had a wonderful executive assistant with type 1 diabetes, very brittle. And of course, she had multiple hospitalizations and ER visits, typically a dozen or so a year. And so one time, I'm at work, I get a phone call, she's not coming in, what's wrong? Well, my foot ulcer is bleeding. Yeah. Now, in the New World Order, I would say, okay, stand by, we're dispatching help to your home. Whereas when she was with me, I had to say, well, go to the emergency room. And that engendered a hospitalization, which, by the way, was a high-margin DRG for Jefferson, and they were more than happy to have her, right?
Absolutely.
But in the difference today, if I'm in an Oak Street, Iora, Absolute Care practice, I would have dispatched the team and go debride the thing, give her IVs and antibiotics at home, prevent the ER visit, and certainly prevent the downstream hospitalization. So it's all about, you got to go upstream. And if I had the wherewithal to direct the team, I think that'd be very satisfying. I didn't feel good sending her to the ER.
Let me ask you both a question about that, though, because, the team, as it's affiliated with the hospital or the primary care, has good vehicles for communicating with each other through health records. But what if I'm the housing agency or the food insecurity resource in the community? How do we build systems that can accommodate the communication channel so everybody's part of that care team?
Well, what a great question. And private equity and other investors know here's a great opportunity. So we got to get to our listeners the William Blair private equity report from less than a year ago on the burgeoning for-profit SDOH industry that's evolving to answer exactly your question, Alan. In other words, guess what? There's a company that will help you do exactly that. I had a dream the other night. I know it sounds corny. Can you imagine one day a patient is at the food bank where you sent them with a prescription, and the food bank manager asks the patient whom you sent, gee, Mrs. Jones, did you have adequate transportation today? Can you imagine that happening one day? And that it's in her record, and you as the primary care captain, you learn about that interaction. Then I'll know that we've got Pop Health pinned down, right? But I think the short answer to Alan's great question is, you're right. I mean, you can't expect the food pantry to be hooked up to Epic yet. But there are other tools, right? Innovacer, InfoMC on the behavioral side, Z Omega. I mean, there's 10 of them, but are trying to do exactly that. Make these kinds of unusual out of the hospital four-wall connections so that people could sort of say, gee, what was active or passive in getting you here today or preventing you from getting here? Pretty exciting.
Another example is here in Philadelphia, there's an organization called MANA. They provide food for...
Big Bertha.
They provide food for patients who are just coming out of the hospital or have a temporary health need. MANA is now part of our Health Information Exchange. So it's become part of HSX, our regional health information exchange, because they are now a player in the healthcare space. And by doing that, they can access some of their patients' health data, and vice versa. The healthcare providers can know this patient is being seen by MANA and is getting support from MANA. So it also shows you that these types of organizations are becoming part of the greater healthcare ecosystem.
Thanks, Harm. I didn't know about MANA being connected to the HIE. That's great. That's really great.
Yeah, and I think there are a number of examples across the country where the bridge is being built through the HIE or other resources where community collaboratives are sharing information. They're building a similar project here in Cincinnati that's trying to link all of the social organizations together. So it is an exciting time. Let me move us forward because this relates very directly to our next question, which is talking about patient engagement and social determinants. And I want to call for your attention in this question, sort of the difference between an individual's health behaviors, which may be how they take care of themselves, how well they diet, exercise, and behavioral health conditions, and you all reference loneliness and depression. How do all of these components play in trying to address or develop social determinant interventions?
Wow. So we know from David Kindig's original work now, almost 16, 17 years ago, that individual behavior, well, that's almost 40 to 50% of the story about health, right? And we also know that a very small percentage of Americans do all the things that are recommended. In other words, don't smoke, wear a seatbelt, are close to an appropriate body mass index, eat their fruits and vegetables, and drive 55 miles an hour. That's 3% of the population. That is a tiny, tiny percentage. So we have a disconnect, because if you're in poverty, well, you're not going to eat your fruits and vegetables because you're in a food desert, so that's not going to work. So there's a really complex mix of stuff here in terms of individuals' health behavior, 50% of the story towards health, and behavioral health conditions, some of which, of course, is unavoidable and inherited and based on geography. So I think that calls for different interventions, is what I would say. Mm-hmm. For certain kinds of patients, patient education, closure of the feedback loop, text messaging, behavior modification tools, that could all work. For other parts of the population, that would clearly not work. So I think we got to segment, is the verb I'm thinking of, segment the population appropriately and apply the technology appropriately. So, for example, my millennial children, well, they would probably pay attention to a text message. They don't pay attention to me, but they'd pay attention to a text message. But I think my, poor, middle-aged folks who I take care of with hypertension, they're not going to respond to a text message. So we got to be careful about what is the appropriate technology to engage, and we have to segment the population.
I agree, David. And I think when we talk about patient engagement, we often go toward apps and technologies to connect with the patient. And
for some people, that would work.
I think right. I like it. I think it's important. But I agree with you, and I'm also somewhat skeptical about it, because in many cases, those who need it can't or won't use it, and those who can use it don't need it.
Right.
So it's not a perfect fit to the population we're trying to address. And, and I think in some cases it may be, but in many cases it's just not the perfect fit.
And
and to bridge that gap, if we don't have a perfect fit, we go right back to the human role of care manager and care coordinator and social worker to bridge that gap.
Which is still a key part of this question.
I think so. So patient engagement may not be an app, but it may be a personal interaction through a care management team. And that, for our truly high-cost, high-need population, may be the most effective way to do it.
Yeah, I think this question also gets us to the part of the conversation, Harm, that's really sad about the diseases of despair, right? I mean, we can't ignore it, especially the behavioral health pieces. So, depression, alcoholism, suicide, and drug abuse, the four horses of the apocalypse, right, have pushed life expectancy backward in the nation for the first time since the Second World War. And we're talking mainly about white rural America, mostly. So maybe there, some kinds of technology would work. Again, if the payment is in the right direction, we'll reach out to these people. But this is going to be a tough nut. The behavioral issues, again, most medical, pharmacy, nursing training doesn't include behavioral economics, the psychology of addiction, nutrition, exercise counseling. I mean, none of that. So we got a long way to go on this question.
Here again.
And our next, let me move to our next question, if I might, because you're getting into the technology issue some. But let me close this one with a quick comment that I think what you're also saying is that there's a difference for how to address population health versus individual health, and there may be a need to collect different kinds of information and craft different kinds of approaches, whether it's a broad community intervention or it's an individual intervention for somebody who has disadvantaged living situations that make it hard for them to take care of their health. So if I take us ahead, and we've been talking about this some, so can you all talk some about how healthcare organizations and others are addressing the social determinants in populations, in practices, and communities? And I'm particularly curious your comments about what technology tools you've seen that may be useful in some of these initiatives.
Sure. Okay, for me to go first?
Yes, please.
So
Sure.
I'm so lucky to have spent 10 years on the board of the Humana Corporation in Louisville. So a Fortune 100 company, one of the top 5 managed care companies in America. So the core corporate goal, the so-called bold goal of Humana, is 20% by 2020. That is to demonstrate in key marketplaces where Humana has a market presence, obviously, a 20% improvement in the health of the population by 2020.
That's in 3 weeks.
And that's in 3 weeks.
All right.
And, on it. And the answer is, in certain communities, yeah, amazing.
Mm-hmm.
And this took an incredible amount of hard work on the ground, connecting with the churches, the synagogues, the YMCA, the grocery store, the school district. No doctor is trained on how to do this. So I think they recognize that improving those social determinants had a business imperative. Lowering inappropriate testing, lowering utilization, keeping people out of the hospital, basically, one more time, going upstream to shut that faucet rather than mopping up the floor. And the bold goal was all about shutting off that faucet. I think another great example was our super friend, Jeff Brenner, of course, who became famous in all of his work and his writings and getting the MacArthur Genius Award, now at United Healthcare, big bad United, #1 insurance company, largest employer of doctors in America, right? So Jeffrey's gig there is he's building housing in certain markets, right? Because what they figure out, well, if you're homeless, you're never going to get out of the hospital. So I think, say what you will, like Leona Helmsley, Humana, United, they run a heck of a ship because they're economically incented. Let's be real here. They're returning shareholder value by keeping people out of the damn hospital. So those are two examples.
Those are good examples. And I would like to refer to a paper in Health Affairs, which I will include in our follow-up document, that gives a good model for this. And I think the concern here is that if a health system wants to address social determinants, their first reaction would be, it's outside of our mission statement. We provide healthcare. It's not our job to provide transportation or food or housing. So it requires a bit of a stretch for the health system to say, well, you know what, we might have to provide that for our population. But then the concern is, if we do it, we're helping not only ourselves, we're helping our competitors.
Right.
And how do you do that? So I think what this paper outlines,
that's a tough one.
It's very tough, but they outline a economic model by which health systems in a city or in a region can do this together and say, let's tackle this together and divvy up the cost for the program and then fairly distribute the benefit of the program. So I think it requires this model for a project that gives shared participation and shared benefits. And that's very well described by this Nichols and Taylor study in Health Affairs that really looks at social determinants as public good.
Public good, right.
A new approach, the article says, a new approach to financing key investments in healthy communities. And that's what it's about. So I don't think it's something that a single health system should do because of the concern that they might be helping their competition, but do it together and fund it together, and also be aware that you're equally sharing the benefits of your program. That may be the way to address that.
Well, I think also, great answer, Harm. I think establishing these goals and then working towards them, right? So what are the metrics against which we're going to be measured? In English, how do we know if we're doing a good job, right? So some of that has to be, well, what are the measures of health, not the process measures or the hospital-based Joint Commission quality measures, all of which, of course, are very important, but this is a different type of measure we're talking about here. And the technology, well, I think we covered that pretty well already, of how you segment the population.
well, let me move us on to our last question, and then we can open it up for some of the questions we've been receiving. So, do you think there are any ethical, social, or other considerations that should be addressed in programs that collect data on individual social determinants or seek to intervene in people's lives in order to improve health outcomes? I guess the question boils down to where are the boundaries, and is everything fair game? And this is a whole new dimension. So, what are we looking at?
Boy, great question. I think one of my great pals, Dr. Karen DeSalvo, now Deputy Chief Medical Officer of Google, but let's remember she was Commissioner of Health for New Orleans during Katrina. She could probably answer this question pretty well. Let me tell you the story, because she spearheaded an effort to get folks to ask these kinds of questions of people in New Orleans, and there was some pushback. And I'm not comfortable telling you about, Uncle Joe and so on. And so how we do this, I think there are ethical, social, and other considerations that we're just beginning to understand.
Yeah.
And I think a warning sign would be, while it's great that the private sector is investing in for-profit SDOH companies, I think we're going to need to be extra careful about how they use this data. So it presents a challenge.
Yeah.
Definitely. It's a really powerful concluding question.
It's a good question, Alan. And I was in my work evaluating a number of these companies that provide data. And these companies come from different walks in life. And there's one firm that has a background in loan servicing.
Yes, well, there you go. So that could be pretty scary.
It is.
Yep.
And so therefore they think, hey, we have this database with loan information, which really is about bankruptcies,
right,
burglaries,
right,
and they repurpose that as a social determinant database. As a matter of fact, their term was a derogatory record.
Wow.
And I felt, that derogatory term, that may be a term that you can use in loan approvals. It's not a term we use in healthcare. We do not use the word derogatory record in healthcare. Right. So I think that is the line. So you have to be careful that the social determinants you're looking at are not just bankruptcies and crime, but really are about poverty.
Right.
And
but we
food
also know
and environment.
But remember, your credit score and your zip code is all I really need to know about you to predict your lifespan. So I get it. So how are we going to protect this information and use it in the way, and Harm, all your work with the local HIE and the work of our college and our program in population health intelligence, we're trying to tackle some of these issues. We haven't solved any of this yet.
I do think, though, that for this reason that we're talking about here, it might make sense if you're going into an initiative with social determinants to go at the zip code level.
Yes, probably.
So you're not tagging a household or you're tagging a particular person. You're just looking at a population, an aggregate population at a zip code level, which feels to me a little bit less intrusive than trying to track this data on an individual household level. And I think that may be, and I think it's sufficient enough to do what you need to do.
Probably, especially in this town, a city of neighborhoods.
Yes. I think so.
Where zip code really tells almost the whole story.
Right. Yeah. So those are concerns that I think people need to be aware of. Look just beyond bankruptcies and derogatory records. Look for the full social picture and try to not necessarily pinpoint households, but stay at the zip code level. That will help you a great deal.
Yep. It's a great.
Well, I'm going to try and weave in some of the questions we've had in furthering this discussion. So, as summarizing what some people have said. But I guess a question that comes to mind here is back to the question of engaging someone in care. What does it say if I come in to see David as my primary care doctor, and he says, "Oh, Alan, I see you don't have a car.
Right.
Do you need help getting to the clinic?" And we've never had that discussion before.
Right. Well, great, Alan. I think again, I've never been trained to either ask these questions or to know how best to deal with them. I think mea culpa, but I'm a product of a different generation. I'm happy to say that in our very large internal medicine residency training program at Jefferson, and if you look across our enterprise with, thousands of house officers, we're making an effort to get to these kinds of issues. But there aren't sufficient faculty with expertise on even how to teach this yet. So I think we're going to make a lot of progress. and hopefully the next generation of doctors will be able to tackle some of these issues. Really important.
So related to this, another question that came in had to do with the different. You all have been talking about the primary care and the role of these social determinants in primary care. What about in specialty care? With surgery or other special areas.
Way more complicated.
Mm-hmm.
So in
say something about that.
Well, so I think in multi-specialty group practices that are bearing risk, that's where this comes into play.
Mm-hmm.
So I think of great practices, Oxner, Mayo, Caremount Medical in Westchester County, where the specialists are part of the woodwork,
mm-hmm.
and also I would argue better part of the solution.
Yeah.
That you're not going to send to every cardiologist, because only 4 of the folk cardiologists really return the patient to the primary care doctor, do the appropriate follow-up, understand the social determinants. Oh, and by the way, get good outcomes at a reasonable price, right? So the only way the specialists participate in this is when the group is bearing risk, or I guess in some of those bundles, and we haven't really addressed the bundles, we mentioned them,
mm-hmm.
but in the joint replacement bundle, the heart failure bundle, boy, I want a cardiologist in the heart failure bundle who she knows what she's doing.
Yeah.
And is not a profligate tester, because if she's a profligate tester, she's going to sink whatever margin we're going to get out of that bundle.
Yeah.
And, our listeners know exactly who I'm talking about. Admit to 7 West, consult the usual,
yeah.
and ultrasound Q day.
Yeah.
That kind of behavior, that's going to sink my bundle.
Yeah.
So we don't want them. So to get specialists to participate, it's a different kind of cat.
In many of the performance measures we see, it's about ED visits, hospital visits,
right.
and specialist
and
utilization.
Also, let's face
it has become a parameter.
And let's call it out. Care coordination, as you've been saying, Harm,
right.
Go reach a specialist on a Saturday night, right? Who's covering, who's in charge. You got to have systems
mm-hmm.
and processes in place
mm-hmm.
to answer those questions. You want to prevent that Sunday night after a big dinner hospitalization and Mrs. Jones had too much food, how are you going to do that?
Yeah.
You got to have a team.
This value-based care is definitely causing a shift from specialty care to primary care.
Yep.
And primary care physicians are being asked to take care of a greater burden of disease management for diabetes, for renal failure, which is, I think, at the end of the day, a good thing.
Yeah, but we're still going to need our specialist colleagues. No way around that. But I want specialist colleagues who are in the boat with me, rowing in the same direction.
That's exactly right.
Right? Not going to ram me,
right.
But are in the boat rowing with me.
Right.
And that is not always easy to find for lots of complex reasons.
Mm-hmm.
So it's challenging, and I think what you're saying is that healthcare of the future is going to look a whole lot different than it currently looks. We've just got a couple minutes left. I'm going to give you each a minute or so to provide a summary, then I'll provide a summary, and then we'll tell people how they can receive additional information after this webinar today. Harm, you want to go first?
Sure. I would like to wrap up by pointing to the importance of social determinants, let's go back to the beginning, driven both by the change in payment model, which causes our providers to look beyond just the care we deliver, but who's the population I'm responsible for, and look not only at someone's healthcare needs, but their overall needs. I think it will make us much smarter in delivering care to the right people in the way they need it and avoid unnecessary care. And I see that in many of the practices we talked about today. They have figured out a way to do a much better job and are making money by doing it. And that, of course, is the wonderful thing here. Secondly, I have a health informatics background. I think these programs are driven by data. I think that's the first step to do. Get your hands on data and then go from there.
It's the information, not just the data.
That's right. From data, you build that into the information, but I would love to match up clinical data with social determinants and to see that combined picture. I think
powerful.
That would be a good initiative.
I sure hope I live to see it, Harm. That's important to me. Well, for me, let me say once again, thanks to you, Alan, and Harm, my amazing colleague, and to InfoMC for their support and to all the people who took time out of their busy first day back after Thanksgiving to listen to our conversation. These are important issues for the country. Healthcare is the biggest business in America. Let's not forget. And if you want to have a future of public education and bridges that work and trains that run on time, we better fix this problem, because there'll be no other money available to spend on our infrastructure. That's one take home from me. And I guess my final take home, I can't resist: no outcome, no income. Let's say it one more time: no outcome, no income. If we don't do it right, you ain't going to get paid.
So, and I want to add here also, David, these are all the concepts that are being taught here at the Jefferson College of Population Health, the school that you founded. And I think this is what we're trying to achieve here, to get a broader understanding and participation in this field of population health.
So let me see if I can kind of wrap it up, if I might.
Alan, this is Dan. Yeah. I did have a few quick questions. I know we only have about 3 minutes left, but I wanted to see if I could get one or two of them answered.
I think we're okay probably on questions. I've been tracking some of them, so I think we're okay, and we'll follow up with any unanswered questions directly. So let me say a couple things in conclusion here, because we are almost out of time. I did want to thank Samantha and the Florida Association of ACOs for hosting this webinar. You've done a really professional and excellent job, and we appreciate that. We are available for additional resources and questions, and Chris can be the collector of those, and we will answer all questions that didn't get answered today. I just want to close by saying that I think when we think about social determinants, it's not a singular solution, and it's a solution that has to be addressed across communities, across practices, across providers, across funders and payment mechanisms. And in some cases, those are all fit together. In others, they may be very different and difficult to coordinate. But this is a challenge, and there are tools and technologies out there that were mentioned during the webinar today to help link the healthcare system with the social care system, and the ability to bring those resources together to help people, and that it's a continuous effort we have to strive to meet. So with that, let me conclude our webinar today. Thank our participants, thank our presenters, and thank the Florida Association of ACOs. I think this has been a very productive and helpful discussion. Look forward to continuing the dialogue online as follow-up. So thank you very much, all.
Thanks again.
Thank you.
And thank you. Have a great day.
Bye.